Hello and welcome to the Wake Up Call podcast. This is part 2 of our interview with Dr. Michel Accad about the history of the American healthcare system. Dr. Accad is a cardiologist and internist in San Francisco. You can follow his work at alertandoriented.com. You can follow him on Twitter at Michel Accad. That's at MICHELACCAD. For more information, please see the show notes page for this episode at wakeupcallpodcast.com/healthcare-history-2. One of the next milestones, shall we say, in the American healthcare system was the creation of Medicare and Medicaid in the mid-'60s. So why were Medicare and Medicaid created? What was the problem that they were supposed to be solving?
Right.
And what problems have they created themselves?
Right. So because once companies were encouraged to purchase health insurance through these laws that made health insurance not subject to payroll tax, once you had a lot of employed people with health insurance utilizing more medical care, that made the cost of medical care more expensive. And that was a problem for people who did not have medical insurance. And predominantly, that was a huge problem for retirees and senior citizens who did not have health insurance, who were seeing the cost of medical care rise and rise dramatically. And who, by nature, by the fact that they were getting older, were needing to use more. So they were really in a huge bind, in a huge financial bind, seeing, becoming older, having a legitimate greater need for medical care, and seeing the costs of medicine increasing. So there was a lot of political pressure to address this situation, and that political pressure gave rise to Medicare and Medicaid laws, meaning laws, that would provide subsidies, or actually would make the government be a provider of insurance for senior people who were not employed. And so that's the reason why Medicare was passed, was because the cost of medical care for older people was so high. Now, it was not recognized in those days. It was not recognized that the cost of healthcare was due to to health insurance, to employer-based health insurance. The argument that was advanced was that healthcare was expensive because of scientific advances, because there were, technological and scientific advances after World War II. People said, it's expensive because technology is expensive. But that's really not an argument that withholds scrutiny. In general, scientific advances are not going to. Yeah. If anything, they make things cheaper and more efficient. But that was the argument used, and then there was a lot of public support for Medicare because everybody recognized that it seemed very unjust for senior people to bear the burden of this out of control price inflation.
Right, and we also saw the government taking over an increasing amount of payments for healthcare.
Yes. I mean, once the government starts paying for healthcare, then all kinds of problems emerge. And initially, in order to get the buy-in of the medical community, the medical community was divided in regards to medical care. There were many doctors in favor of it, but some doctors were skeptical or concerned that if the government started paying for medical care, they would interfere into the practice of medicine. So at first, the provisions of the Medicare Act was that the government would not interfere whatsoever in medical care. But that was obviously unsustainable because, the minute the government agreed to pay what was called the usual and customary fees, meaning, without any price control, there was absolutely no end to how much medical care would be utilized. So there was a huge utilization of medical services from all these senior people who obviously are getting older, and as they get older, they need more medical care and so forth. So it spiraled out of control, and so that by the 1970s, it was apparent that it was unsustainable, and that the initial proviso that the government would pay the usual and customary fee would have to be rescinded, and that price controls of one form or another would have to be imposed. And that's essentially what's been going on for the last 30, 40 years. It's been attempts to introduce price controls in one way or another, all of which have failed for the most part. Because, again, when you when you agree to pay for healthcare, it's very difficult to ration it, to impose effective price controls. There are always ways for that insatiable demand for healthcare to be satisfied, and so the attempts that have been made over the last 40 years have been essentially bureaucratic attempts to try to distract the doctors or demand more documentation for justification of healthcare, or try to get doctors to follow strict guidelines and that sort of thing. But it's not really working. It's just making everybody more upset, and it's not doing much to reducing the cost of healthcare.
Right, and all of this is just further proof of how far removed the U.S. was from a free market healthcare system, even before the enactment of Obamacare.
I agree. Obamacare is just the logical continuation of a trend that started, 100 years before. There was nothing. There hasn't been any free market since the enactment of licensing laws, and that essentially set off a chain reaction of interventions and unexpected consequences, and then further interventions to deal with those unexpected consequences. Nobody ever goes back to question the wisdom of the prior interventions or the initial intervention in the first place.
And let's talk a little bit more about Obamacare. Can you give us a little brief kind of before and after Obamacare comparison of what the healthcare industry looks like right before and now immediately after?
Right. So right before, health insurance. So people have become, since the enactment of Medicare, and even before, but certainly since the enactment of Medicare, which enabled this huge demand for medical services and caused a huge increase in medical price inflation, people have become naturally dependent on having health insurance. If you don't have health insurance in the U.S. and something happens, you can be ruined. And there were, clearly many cases of people being bankrupt for not having health insurance and having some medical illness. And so there was a huge pressure to try to remedy this by forcing an expansion of health insurance to people who did not have it, despite the fact that they were employed, because frequently, so let me backtrack a little bit. This increase in demand that is initiated by the proviso of third-party payment, by the provision of health insurance. Once you provide health insurance, you increase demand for medical services. So how does a health insurance company respond to that? It has to respond by increasing premiums, because if you say I'm going to insure a population of people, and you make some actuarial analysis, you say, well, at time t equals 0, at this time they're utilizing so much health services, and we're going to make some actuarial analysis and decide that premiums at this level will be enough to take care of things. And then you give people health insurance, then their utilization of healthcare increases. So so then you have to play catch up. The next year you have to rise your premiums, because the current premiums that you have are not sufficient to cover healthcare. So you have to increase premium, and that's been the story since the introduction of health insurance. That premiums have increased, above the general inflation level year after year. And so over time, it's made it very difficult or very expensive for individuals to purchase insurance on their own. And then companies have been less and less able, small companies that have not been able to buy health insurance to their employees. So in the years leading up to Obamacare, it was a huge crisis that people knew that they couldn't survive without health insurance, and then there was pressure on the government or interest on the part of the government as well to expand health insurance, to make it available to everyone, essentially by mandating it, by requiring all individuals to purchase health insurance, with the argument being that if everybody is forced to pay a premium, there'll be a sufficient pool of healthy people to subsidize the rest of the country, and so that's what happened. It was not Obamacare was not in any meaningful way any change in the way healthcare was was going to be conducted, at least on the surface. Now, there was a lot in the nitty-gritty of the law, which is a huge law that, as you probably have heard, nobody has really read before it was passed. But on the surface, it was just an attempt to expand the availability of health insurance to more people, so that there'd be a sufficient pool of quote-unquote healthy people to subsidize those that are not so healthy. And we're seeing that it's not working now. So post-Obamacare, medical price inflation continues to rise, premiums continue to rise, and it's going to fail, and there will be yet another measure to address that failure of interventionism.
So do you think that next level of interventionism is going to be a single payer system? Can you explain, for those who aren't aware, can you explain exactly what a single payer system is?
Right, a single payer system would be essentially the government taking at this time. What Obamacare did, it facilitated it by forcing individuals and companies to purchase insurance. It provided a market for private health insurance companies like Blue Cross and Humana and all these companies to operate. So for the time being, it's still apart from Medicare. It's still, there's still a private market for health insurance companies to provide, to pay for medical care. What a single payer would do, it would essentially eliminate those health insurance companies as such. They would no longer be working as health insurance. They might reinvent themselves in another administrative function. Who knows? But the idea would be is that it's the government that would pay for the cost of care. And whether that will happen or not, it's unclear. But it would pay it through the general fund, I suppose, or but in essence through debt, through more debt. It would pay for the services. There are different possibilities of how exactly that might take form, but and nobody's really officially talking about it in the administration, as far as I know. But that's a possibility. Although I really cannot predict how things are going to turn out. I predict there will be a huge crisis, but how this will evolve is hard to know. There's sufficient opposition to the idea of single payer healthcare that it may be hard to pull off.
Right. No, there definitely is a lot of opposition to it. But from those who advocate for single-payer systems, a lot of the time they'll point to these systems being in existence in other countries. So what successes and failures have we seen of single-payer systems in other countries, in Western Europe and Canada and elsewhere?
Right. So they're very treacherous comparisons. So I think if you get down to the nitty-gritty, you can see that outcomes are worse in other countries compared to the U.S. But some people may say, well, they're not meaningfully worse. If you look at one statistics, meaning the health expectancy, or the average life expectancy. Life expectancy. That life expectancy in Western countries is about the same as it is in the U.S. Yet in this current system, we spend so much more money. There has to be a lot of waste, and therefore, if we adopted a single-payer system, we would reduce the healthcare expenditures. But that's really a faulty way of looking at it. Number one, it's clear that there are many more restrictions in access to healthcare in other countries than is the case here. Many of these other countries, the government controls the number of hospitals. So it has it can tell. Like in Canada, the government will decide how many hospitals can be opened per X numbers of people living in a certain geographic area. It will control the number of MRIs. So you will have waiting lists. You have huge waiting lists, and so that'd be a huge change if that happened here. But one thing that people don't realize is that the innovation in healthcare that took place in the U.S. through an admittedly really crony system, because American healthcare is a crony system when you have such public financing, through Medicare of a private industry, a private healthcare industry. It's a crony system, but nevertheless, it has led to a lot of innovation that are exported essentially to the rest of the world, because England and Canada and France and all these other countries benefit greatly from a lot of the inventions and innovations and pharmaceutical development that occurs in the U.S. by virtue of this crony capitalist system that we have. So if we eliminated this, if the U.S. turned into a single-payer healthcare system, then you would see, or you may not see it, but you can imagine a fairly drastic reduction in innovation, and it would be a lot worse. Overall, at least it would be a big change than what it might be otherwise. People don't realize. So if you imagine the British system, if it wasn't for U.S. inventive, by far most of the innovations of the last 50 years have come out of the U.S. I'm not saying that the other countries have not contributed, but it's overwhelmingly the case that the U.S. has been innovative. So if you look at the British National Health Service, the NHS, which started off as a single-payer system in the 1950s after World War II, if it wasn't for the innovation of American medicine, the British would still be practicing 1950s or 1960s type medicine to this day, right? Because there'd be no incentive and to innovate, and you'd have a lot of bureaucracy and government intervention in healthcare that would make it very difficult for innovations to see the light of day.
Right, and of course with these single-payer systems, oftentimes you see extremely long waits to get care. You see extreme shortages of doctors. You see some types of care completely phased out because of those shortages. There are all sorts of horrible
That's correct.
That's correct.
And that's correct. And we're starting to see those here as well. We're starting to see those here certainly in certain in the drug market, in the generic drug market, we see a lot of shortages in some very simple items that if this were a free market, we would never see shortages like this, but we see them. So you're right. At some point, just to give you an anecdote, I was a few years ago, I used to work for a large health maintenance organization, and I was asked, as a cardiologist, I was asked to see if the patients who were admitted to the hospital with an acute heart problem and were they were waiting in the hospital to get their bypass surgery. They needed to have bypass surgery, and the standard in the U.S. is to do the surgery immediately as soon as you detect the problem. On the same admission, the patients get admitted. You find that they need surgery, and you operate on them, because if you don't, then there's if you delay it, there's a risk that a catastrophe could happen. But nevertheless, the administration of this organization asked me to comment on what might be the consequence of sending those patients home, because they were concerned. They wanted to manage their bed utilization, and they thought that these patients were waiting too long in the hospital to get their surgery. They were interested in sending them home. Well, I did a literature search, and it turns out that there's a lot of research coming out of England and Canada, where they actually document what they call the attrition rate, meaning the people who die while waiting for their bypass surgery, because it can take up to 6 months or even more to get a bypass operation in England or in Canada. So it's clear that there are consequences. Now, what happens is that in the culture, people are used to that in other countries, and they don't. It's the Bastia, the famous saying. The unseen. They don't pay attention to the unseen. When somebody dies waiting for surgery, if you don't know that there, could have been an alternative, that they could have had their operation sooner, you attribute the death to the disease as opposed to a failure of the system. So,
are there any things to look at on the bright side? Are there any positive changes that might be coming in the near future?
Yes. There's not huge change. There's a very important. They're modest changes, but I think they're really critically important. There's a movement in the U.S. Called direct care medicine, or direct primary care, where it's doctors decide to opt out completely of the insurance business, whether it's private insurance or government insurance. They opt out completely, and they ask patients to pay for their care on a cash basis. And you find that in settings like this, the costs of care are much, much lower. because for the doctor, the overhead is much, much less. They have much less, much fewer regulations to deal with, and they don't have the overhead of having to submit all the documentation and all the paperwork and all the red tape to the insurance company to get paid. So they can provide care that is much cheaper, and patients are much happier because they get to see their doctor quickly. The doctors don't have to have a panel of 3,000 patients in order to make ends meet. They can have a smaller clinic where they can take care of maybe 300 to 500 patients. So it's a lot more personal attention to each patient and much more individualized. So that's growing rapidly in the U.S., and I think it's a very, very positive trend. It's a little more difficult to provide more technology intense care, but even that there are some interesting practices emerging. There's a center in Oklahoma called the Surgery Center of Oklahoma. Started a few years ago by a doctor named Keith Smith, who's really a visionary pioneer who offers, again, he's managed to get a bunch of very good qualified surgeons, orthopedic surgeons, ophthalmologists, and general surgeons, and so forth, to provide outpatient surgery on a cash basis for a very, very transparent price, so that when people go in there, they know exactly how much it's going to cost them. It's a lot less than the price that would be paid if it was provided through the insurance system, and they're having very, very good outcomes, and they're attracting a lot of attention. So the more enterprises like this emerge, the more it will provide alternatives to the system that will make care a lot better and a lot cheaper. So there's hope from that standpoint. Another area of I don't follow it very closely, but I think it's very interesting. There's, I think, close to 1 million people who are participating in what are called cost-sharing ministries. And cost-sharing ministries, on the surface, sound like they're a type of health insurance, but they're not really health insurance. It's generally a group of folks. Typically, they're church-based or religion-based collectives, where they voluntarily decide to pool money, or so a person would pay voluntarily a certain amount each month to this organization, and the organization would agree to pay for to pay the patient for the cost of their care should they have a catastrophe. But it's not guaranteed that they will receive the pay, but there's an honor system going on that provides a little bit of coverage, or security. It's something that was common in the Amish community, and I think it was copied from what the Amish used to do and expanded to other groups. But essentially an honor-based system for a community to get together and say, we're going to be very restrain our utilization of medical resources. We're not going to be getting our care that's on a whim just because somebody else is paying for it. We're gonna try to self-limit our expenses. But if somebody has a catastrophe, then we'll agree to do what we can to pay for that person's medical bills. And from what I understand, it seems to be working pretty well. And so that may provide an alternative to the health insurance system that does not drive the utilization of medical resources the way health insurance does.
Well, it's great to know that there are alternatives out there and that there are some reasons to be optimistic about this whole situation. But in the meantime, if someone wants to learn more about the history of the American healthcare system and about the current setup of the American healthcare system, what readings or resources do you recommend they check out?
Well, they can check out my blog, alertandoriented.com. There aren't too many places. Much of the healthcare commentary from healthcare economists and whatnot it's pretty much wonks having opinions about how to tinker with the system, and somebody saying they have a better idea about, as opposed to being really pro free market and seeing the value of letting people decide for themselves, how to organize medical care. So I don't know of any too many resources that are free market oriented as far as healthcare is concerned. But if I do find them, I'll point them out on my blog. And so if they follow me there, that may be a starting point.
Okay, great. So obviously alertandoriented.com is a good way to follow your work.
Right.
What other ways are there to follow your work?
On Twitter, I'm fairly active on Twitter at Michel Accad, MiChelAccad. And there are professional organizations. I should mention there's an organization called the Free Market Medical Association. It's primarily for health professionals or for doctors who are interested in setting up a practice that is cash-based or free market-based practice, the Free Market Medical Association. And there's an association called APS, the Association of American Physicians and Surgeons, which is also very friendly to enterprising free market oriented doctors. But those are primarily directed at health professionals, but they're worth mentioning.
Okay, sure. Well, I want to remind everybody to go check out the show notes page for this episode. That's wakeupcallpodcast.com/healthcare-history. And, of course, we'll link to alertandoriented.com. And one resource that you didn't mention, but we'll link to there for sure, is The Primal Prescription, which is a book by Bob Murphy and Doug McGuff that has a lot of information.
Thanks for mentioning that. You're right. I failed to mention that. That's a very good book because it does give a very good historical overview of what's happened in the last 100 years, and also it points to interesting developments that can be useful at a practical level for people.
Right. So we'll definitely link to that book, and we've had both Bob Murphy and Doug McGuff on the show as guests, so we'll link to those episodes as well. So the show notes page for this episode is wakeupcallpodcast.com/healthcare-history, and all of those resources will be available there. And I want to encourage everybody to subscribe to the show on iTunes or Stitcher or the podcatcher of your choice to make sure that you never miss an episode, and to sign up for our email list and follow us on Twitter at WUC Podcast, both of which are great ways to stay up to date on what's going on with the show. And on that note, Michel, thank you very much for joining us today. This is a confusing and complex topic at times, but there are a lot of twists and turns in this, and I'm glad you were able to help us sort it all out.
It is. Thanks for giving me the time. Thank you very much. It was a real pleasure.
All right. Well, thank you.
Thank you. Thank you for listening to this episode of the Wake Up Call podcast.
If you would like to listen to more episodes, please subscribe, rate, and review the show on iTunes, or subscribe on Stitcher, and check out our website at wakeupcallpodcast.com.
There you will find show notes pages and comment sections dedicated to the show. You can also email us at contact@wakeupcallpodcast.com if you're interested in being interviewed for the show or have any other suggestions.
Thank you.